Now this may appear to be a very routine cataract, and of course it is, and this is the fundus, but we'll see the moment the surgical video starts. And as we can see, there's something wrong, and we can see everything is so shaky. It appears as if we are traveling in a bus or a train which is having jerks, and then we are looking at some object. But this is tutubation or titubation, which is nodding of the head and side to side or vertical, and this motion is usually very rhythmic and involuntary, and usually when the patient tries to control it, it becomes severe. And this is due to central nervous system diseases. Remarkably, Parkinson's is one of them. So this was a lady who was having this kind of cataract, and when we saw her in the OPD, we could see that she had this kind of motion. And as we can see, this is troublesome. Now, eye surgery, especially the phacosurgery, is a microsurgery where it matters that you have good view, stability, and this is all because we need a significant amount of precision. And if the things go not controlled well, they may end up into having a complication. So having a stabilized head, stabilized eye is very important, and that is why we all have the kind of situation that we ask the patient to keep the eye and face stable. But here this couldn't be helped. And the problem is that this tutubation is usually involuntary, and when the patient tries to control it, it becomes even more worse. Another option is that going for a general anesthesia kind of thing, but then these patients already have compromised issues, so general anesthesia has so much of post-op issues, and the anesthesia may not be very safe. Now, drugs which sedate the patient can also increase this jerking or nodding because of extrapyramidal symptoms which they precipitate. So these are all the available options, and out of which one is that you yourself can prepare yourself and adapt to the situation where this jerky motion is compensated by the motion of your hand and eyes. And believe me, I started having a nystagmus sort of motion in my eyes during this surgery, and as I can predict that those who are watching it also may start experiencing a nystagmus like motion in their eyes, and that can't be helped. But overall I felt that it was not very challenging. If you can simply catch on to the rhythm of the motion, you can actually perform this surgery. And I can't help but get amused that how I was able to do this surgery without any expected complication which could have happened because of these motions. And as you can see, we have reached to a situation where we have done a large rhexis, and now we are doing this chop. And at this moment my probe was little out with the aspiration on, so we had little collapse of the chamber. And then I registered this, that we have a situation where I should not pull out because it is a relatively small diameter cornea, so we'll have less space. So progressively engaging the nucleus and chopping it, and by this time the eye has moved little away towards the lower portion of the camera field, so we may not have the complete view, but we'll just see how it proceeds. Now I have deliberately not edited out any portion of this video just to let the viewers feel that how the surgery goes. So I am chopping and chopping and chopping into small pieces, taking care that I don't catch anything extra other than the nucleus, including the iris. The pupil is not very well or ideally dilated, but it is good enough for the surgery. So once we have achieved number of chops, and we can see the chops are small, then we proceed to emulsify them. So this is Apasami robot machine, which has orbit cool mode, which is basically micropulse mode, which causes less of turbulence and repulsing of the nuclear pieces so that the followability of the pieces is better. And all this time the patient was making these movements, and I didn't urge her to stop making this movement because it is uh, limitation that she cannot actually control it. It is all involuntary. The more she makes an effort, the more vigorous or the amplitude of the movements increases. So we'll have to get the surgery done with this compromise in place. As per my experience, I felt that Rex's was challenging because of this motion, and emulsification process didn't pose much of a challenge to me because you have some space there, relatively greater space and greater margin of safety. However, when coming to cortical aspiration, then the things are more challenging because then you are working very close to the capsule, which may get traumatized because of the procedure. So this is the epinucleus which has come out, and now we are left with only some amount of cortex here, and we'll switch to irrigation aspiration cannula. The movements are still there, can't help them. Replenishing some viscoelastic before proceeding for cortex aspiration because protecting the endothelium by coating it with viscoelastic or a dispersive viscoelastic is a best choice. The patient otherwise was very cooperative, and she was not moving her head in a manner that we usually have those patients who are less cooperative, and she was keeping as much as her condition would allow. She was keeping her eyes stable. So this is actually not ocular movements, these are involuntary head movements which we just can't restrain. And all other options are not very ideal, so if possible one can go for removing the cataract in this present condition itself. So I could see that there is some subincisional cortex left behind, but then I thought that this will be safer if we can polish it, or we can implant the IOL and then see if we can remove this cortical matter after implanting the IOL once we have some shield for the IOL. And for that what you can do is you can scoop the cortex away from the posterior surface of the posterior capsule, and then you can implant the IOL so that this cortex is not trapped between the IOL and the capsule, and then it can be aspirated once the IOL has been implanted. This is a preloaded IOL from Appasamy. This is supraphobe, and it is an excellent IOL. I never had a problem with the loaded IOL in the sense that I never had a traumatized haptic. It goes very smoothly, and as we can see the haptic has gone into the bag, so there's no need to dial it. Going for irrigation aspiration, and first going for that portion where we had some cortex left behind. The pupil is not very large, it is something like 4 to 5 millimeters, and you can see repeatedly it is coming into the irrigation aspiration port, but if you don't pull it too hard, usually the iris is forgiving for these conditions. So removing this viscoelastic taking some time so that adequate amount of visco removal is done so that we can have a comfortable post-op period. One interesting thing which I found while looking for the possible solution for this condition is that cannabis or bhang can actually reduce the amount of these tremors, and I also suggested the patient this, and we jokingly discussed about this issue, and she said that मुझे किसी तरह का नशा नहीं करना, and I also finally told them this is a treatable condition and they should see a neurologist who would be able to maybe treat this using medications. So this was a short incision, and so it was leaking, so I decided to do some incision corneal hydration to seal the incision better. So corneal hydration can work for this situation where you have a short tunnel which may leak, so you can hydrate both the edges, and then this cornea becomes thicker, and the wall which was not so competent may actually hold the contents better. So hydrating the wound so that we have some strength of the valvular incision, and this may work well for us. And then depositing this iris which is prolapsing out, and once you have valve in position, then we can hydrate and inflate the anterior chamber, and we find that it is well sealed. In case it is not, then one may need to put sutures. This is the day 1 picture which shows some amount of corneal edema because there was IOP rise. This is day 3 picture which is fine with a dilated pupil, and this is the day 7 picture which shows a nice round pupil and the patient had good vision gain. Thank you.